Good afternoon, good evening. Thank you so much for joining us for the Mpox special briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. Today, we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based in DRC. And I will now hand it over to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Thank you very much, Director. Good afternoon, good morning, everyone, depending on which part of the world you are. First of all, I'd like to welcome you again to this weekly press conference. And thank you for making the time to join us and get an update on the progress we are making on the Mpox outbreak response in Africa. As some of you may remember, tomorrow will be 28th of February, which marks the last day of the continental Mpox response plan that we launched in September last year. I think this is the end of the first 6 months of the response. We've learned lessons. We also engaged the emergency advisory committees of both WHO and Africa CDC to consult with them on where the outbreak is and also get guidance on whether there was need to maintain or lift the public health emergency of international concern or continental security that was declared last year in August. We have heard from them. Now we are now preparing for the next plan that will cover the next 6 months. Just to tell you at what time we are right now, we've completed the first phase. Now we are ready to move into the next phase. A very warm welcome to all of you. I think with that, Director, we can now move into the presentation. Yes, thank you. I'm going to give you this presentation on behalf of His Excellency Dr. Jean Kaseya, who couldn't join us today. Just to give some main highlights. The first, I will just say that yesterday, the Emergency Consultative Group of Africa CDC, which advises the Director General on public health, on the declaration of public health emergencies, met yesterday, 26 February, and then unanimously made the decision to extend the public health emergency of continental concern on Mpox. And the second major highlight is that South Africa, after more than 90 days that there has been no cases of Mpox, has now confirmed 3 new cases. And also very important information also from the DRC that we have seen a new variant of clade 1A, Marburg 3, that has been detected. And unlike the old 1A variant, this one has got a high potential for higher transmissibility. And finally, we are pleased to report that after weeks of planning, the DRC has finally launched the vaccination campaign in the Kinshasa hotspot areas, as you can also see on the picture on the right, showing people that are really lining up for vaccination as a testimony of the high acceptance among the communities. Now, on the number of cases, in 2025, we have registered so far 21,544 cases that have been notified, of which 5,364 confirmed and 233 deaths among suspected cases and 21 deaths among confirmed cases. And we have all these cases have come from 13 countries that have reported. And just to say that with South Africa now coming up, we have now 14 countries in active phase of the outbreak and 8 countries that are in control phase. I think that makes a total of 22 countries. There is a mistake there. Instead of 9, it is 8. During AP Week 7, there are 12 countries that notified 1,959 cases, 535 confirmed, and 42 deaths among all cases. And that is in comparison with Week 6 that had 36 deaths and 2,838 cases that were notified. Also important to say that South Sudan has now confirmed its clade, which is 1A, and Congo Brazzaville has reported clade 1B, now indicating that just like DRC, in Congo Brazzaville, there are also the two clades that are co-circulating. Now, when you look at the progress since January 2024 up to now, February 2025, you'll notice that we try to compare the weekly averages in the number of cases and also number of confirmed cases and the number of member states, I think that were reporting cases between January and April 2024. There were on average per week 376 cases notified, 55 deaths, and 6 member states that had reported cases. During the period of May to August 2024, the weekly average number of cases notified increased to 909 and the confirmed cases to 186, reaching 13 member states that had reported. In September to December, the number of notification per week tripled to 2,777, and the number of confirmed cases more than doubled to 488 cases. And there were at that time 20 member states that had reported. And then during the first 2 months of this year, the average weekly number of notified cases further increased again to reach 3,264, and the confirmed cases to 805. And we had reached now 22 member states that have been affected, including 2 new ones for this year, which are Sierra Leone and South Sudan. And also very important to say that during that time, we have also seen cases happening outside the African continent, but that were linked to travel in Africa. During the period of May to August 24, we had 2 countries, that was Sweden and Thailand. And during this September to December period, there we had more countries, about 8 of them, that is Germany, Belgium, UK, Canada, India, Oman, Pakistan, and the US. And all these cases were linked to travel in Africa. And it is on that basis, looking at the progression of the outbreak, that the emergency consultative group convened yesterday to review progress and unanimously recommended the extension of the FEX, which is the Public Health Emergency of Continental Security, on this ground. One is that there are several countries that have experienced the continued rise in cases I've just shown on the map, with the continental average weekly report increasing from 909 in August 2024 during the time of the declaration to reach now 3,264 in February. I think that is more than threefold increase. And the second observation is that there has been expansion of the outbreak to new countries, 9 countries after the declaration, and the 2 countries just since the beginning of 2025. And the third factor that played in the decision is the emergence of new variants, particularly the clade 1A outbreak strain, which has shown high transmissibility and also raises serious public health concerns. And the fourth element is the growing conflict and insecurity in the DRC that really makes it very difficult to maintain the current effort with the increased risk of spread to other places within DRC itself and in other countries. And finally, is the challenges that we have experienced with the vaccination programs that have required improved strategies to really scale up much faster and optimize the impact of vaccination on helping us to control the outbreak. I think those are the 5 reasons that really played in the decision to maintain Mpox as a public health emergency of continental security. On the vaccination, as one of the challenges that I've just mentioned, taken into account during the decision, we have now 1.4 million doses of MVA-BN vaccine that have been allocated, 756,000 that have been shipped, and all that, it's 8 countries that have received these vaccines, including even Sierra Leone that received it this week. We have 5 countries that are currently vaccinating, which include Nigeria, Central African Republic, the DRC, Uganda, and Rwanda. We have about 200,000 doses that have been administered, and 12 countries that have already granted the emergency use authorization for the MVA-BN vaccine. Next. Now, the situation in DRC during the AP week 7 shows that the number of new cases notified has been lower than in week 6. 1,463 cases that have been reported, but this is mainly because of the slow reporting from the district and the health zones, also coupled with the low testing coverage, which stands now at only 35% of the cases that are being tested. During the same week, we had 200 confirmed cases and 2 deaths on confirmed cases, but 29 on all suspected cases. Now, the clades, as I said, they had 2 clades that are co-circulating in DRC, that is clade 1 and B. And the test positivity rate stands now at 47%. I think, as I said, the problem in DRC is that we have seen a decline, as you can also see on the epi curve on the graph, a decline over the last 5 weeks. As you also remember that this is the time that the insecurity has grown in the DRC. And with that, we've also seen the testing coverage also declining, which can explain the decline that we see in the number of cases. Just to say, at this stage, we cannot say that the decline is being explained by the control of the outbreak itself, but more on the challenges around the insecurity and the capacity to test. Next. In the DRC, also, as I mentioned, that the good news is that we've had the launch of the new vaccination strategy last Saturday. We started with the area that is the most affected, called Pakajuma. Very interestingly, you see the lines that I mentioned, but in just about 4 days, we have 24,000 people that have already been vaccinated, really showing that with the new strategy now, that is now combining both the traditional vaccination in rings around the contact, but also the geographical vaccination of geographical areas where we have more cases coming with fewer contact. The combination of these strategies is really giving hope to be able to catch up on the 3.5 million people that the DRC is planning to vaccinate this time. And also very important, again, just to remind that the challenges of the insecurity in the East remains. We have more than 2 million people that have been displaced. Very important is that that really has got high potential for spreading the outbreak to other provinces within DRC, but also to the neighboring countries and beyond. Just one thing that happened is that there were more than 500 active Mpox patients that were in the treatment centers that all fled during the armed conflict in the DRC. I can imagine that all those are in the community within DRC and outside, that they really carry the risk of spreading the outbreak. I think there were widespread destructions. I think the health infrastructure and hospitals were destroyed, in addition to being overwhelmed by the growing number of cases that were received because of injuries. There also reported cases of international agencies evacuating their non-essential staff and therefore reducing their capacity to intervene. And despite that, until now, there are still reports of violence, I think, that are happening with sexual assault and looting due to the growing insecurity in the area. That's the reason why, once again, we are calling really for the ceasefire and also the agency to establish a humanitarian corridor to facilitate the continuation of Mpox interventions, in addition to the humanitarian aid that is desperately needed in that area. Next. In Uganda, we have also seen over the last 3 weeks an upward trend in the number of cases. During AP week 7, there were 278 cases confirmed, compared with 192 in week 6, and 2 deaths compared with 3 in the previous week. In terms of the distribution by gender, males make almost 57% of cases, and the circulating clade is clade 1B. But Uganda is doing very well on testing coverage, which stands at 100% now, with a positivity rate of 60%. And there are 83 districts that are affected, of which 52 are currently active. Now, the numbers in Uganda are still on the rise, I think, affecting mainly persons between the age of 18 and 39 years, of which clusters of sexual networks, I think that also pose some considerable challenges when it comes to retrieving their contact for follow-up and vaccination. Next. And in Uganda, also important to mention that the health system is being overwhelmed in some places. For example, the treatment center at Entebbe, which has seen an average of 30 to 40 admissions per day, has reached between 210 and 280 weekly admissions. Now, you can imagine that currently they do have 102 patients in a facility that has got only 80 bed capacity. Just to also explain why, because of this, the leadership in the Ministry of Health has now opted also to introduce home-based care for non-severe cases. That will be now this dual approach, with non-severe cases will be also taken care of at home, while severe cases will be prioritized for treatment in the treatment center at Entebbe. Next. To finish with Uganda, just an update on the Ebola outbreak. I think the good news is that there has been no new cases since the last update that we gave last week. Also important that this is now 9 days since the last case was discharged. Now the countdown has started. It's just 33 days left to the end of outbreak if the situation remains as it is currently under control. In total, there have been 9 cases registered, 1 death. Really very well done in the response, with one of the lowest case fatality rates registered, around 11%. And in the 3 districts that were affected, all of them around Kampala. Next. In Tanzania, it is the same observation of the Marburg outbreak. Also, no new case reported since our last update last week. And it is also in the countdown right now, 25 days since the last date was recorded. That said, there's still 17 days to go to get to the 42 days that are required to declare the end of the outbreak. Next. Now, there is also the outbreak of the febrile illness in DRC that has started since February 9th. This is almost 2.5 weeks that they have been going through this. A total of 943 cases suspected that have been reported, 52 deaths with a case fatality of 5.5%. But just to say that the symptoms include fever, chills, sweating, headache, and muscle pains and pain in the neck, pain in the joint, but also GI symptoms like anorexia, vomiting, and diarrhea, and some cases of dyspnea and restlessness. That to confirm that there is no hemorrhagic symptom, I think that have been reported. But despite all that, the investigation have also included even Ebola and the Marburg that have tested negative. Now, there are 5 villages that are affected, both in Equateur, in the Basankusu region. In terms of the distribution of cases by age, children below 5 years make about 18% of cases with a case fatality of 5.3%. Children 5 to 15 years make 20% of all cases with a case fatality of 6.4%. And in addition, the diagnostic is more pointing toward malaria. I think there were rapid tests that were conducted, about over 500 samples that gave a positivity rate of 55%. But there were also blood smears that were also conducted, around 70 samples, that also gave a positivity rate of almost 78%. As I said, the tests of Ebola and Marburg turned positive. Now the diagnostics is now going more toward malaria, in the context of the weak health system and also very limited access to health services that have characterized the province of Equateur in the DRC. And finally is cholera in Angola. The last update as of 25 February 2025, it is 860 cases that were reported compared to 957 cases the week before. There's a 25% decrease compared to the last report. The case fatality stands at 4%, and cumulatively, that's 5,219 cases that have been reported, of which 870 confirmed, and 189 deaths with a case fatality overall of 3.6%. I think there are 11 provinces that have reported cases, but the epicenter remains in the provinces of Luanda and Bengo. Now, looking at the distribution of cases, first of all, by gender, I think males make 56% of all the cases and 69% of deaths. And the distribution by age, the children less than 15 years of age make 39% of all cases and 33% of all deaths. Next. In summary, we can say that the recommendation of the ECG to extend the public health emergency of continental security is just, again, a testament that Mpox is not yet under control on the continent. It is true that there have been some significant progress that we need to recognize with the beginning of the decline in cases and deaths that have been observed in the last 3 weeks in this year, and also the result that we see in countries such as Burundi, where we have seen a sharp decline in the number of cases. We look at the last 6 weeks, compared with the 6 weeks before, it's about 50% reduction in the number of new cases. And we are seeing the same trend also in the countries that had experienced sporadic cases. However, the trend is still of great concern in 2 countries in particular, in Uganda and Congo, because of the increase in the number of cases, but also in Congo because of the new strain. I think that has been reported now with 1B that has been observed in Brazzaville. But we are also concerned with the spread to new countries that have been reported also this year of Sierra Leone and South Sudan, and the most recent information on the resurgence of Mpox again, in South Africa. In addition to that, the conflict in DRC is just increasing the risk and compromising our effort. And when we also look at the US pause on global health funding, which is already affecting some of the countries like Uganda and DRC in particular, where this funding contributed a lot in the Mpox response in areas such as sample transportation, with the freeze that has affected that we see even the decline in the number of people that are tested. I think these are challenges that we are very much aware of, but as we are moving into now the second phase, as we are preparing our plan, the next phase plan for the next six months, we have identified a number of strategies that will help us intensify our effort and really accelerate our progress to the control of the Mpox outbreak. I think these include the scale-up of community health workers to help us with the community approach to surveillance, to IPC, to risk communication, the decentralization of the laboratory capacity as also a solution to address the huge challenges about sample transportation, the acceleration of vaccination to also protect as a wide population as possible, and the IPC. I think those are some of the measures that the IMSC is counting on to help us accelerate the control of Mpox in the most affected countries in the few months to come. I think, Director, that's why I would like to stop, and I would like to thank everyone for your attention, and then we are open up to take questions and comment.
Thank you very much, Dr. Ngashi. Let's cross over to the floor for first questions. Janice from Bloomberg, you have the floor.
Good afternoon. Thank you so much again. Dr. Ngashi, I just wanted to go back to what's happening with, for lack of a better term, this mystery illness in the west of the country of Congo. You were saying that the diagnostics at this stage are pointing more towards malaria. I guess I was just wondering if you think this is a very similar situation to what we saw towards the end of last year further south, and if you've got any time frame as to when you think the results of the testing will be complete.
Thank you. Let's take the next one before Dr. Ngashi comes in. Paul from the Lancet, you have the floor.
Yes, thank you very much. WHO issued a similar declaration on Mpox, which is extending its status as a public health emergency of international concern. So I'm curious to know from the Africa CDC's perspective, what the major focus of the next phase would be, and will there be additional cost implications for the second phase? And Larry, the last time we talked about US funding freeze on the continent, there was this promise about Africa CDC doing a survey on understanding how exposed the African country is. So I'd like to know if we have insight into the exposure of African countries, how much is at stake, and what efforts are currently underway to mitigate the impact on public health care on the continent. Thank you very much.
Sorry, Margaret. I know this is unusual of me. I meant to have a third part there, if I could just quickly add that before Dr. Ngashi starts answering. Just going back as well to this new clade 1A that has been identified, Mpox. I was just wondering what is making you think it's more transmissible potentially, and how concerned is Africa CDC about this?
Thank you very much, Dr. Ngashi. Over to you.
Yes, thank you very much, Janice and Paul, for those questions. I think if I start with Janice, it is the symptomatology of that disease in the equatorial region is very much similar to what happened in Panzi last year. And it's almost the same trend that there were investigations that covered almost everything, Marburg and Ebola, but at the end, it turned up to be malaria. Now, what does that mean? It's exactly where this whole thing is also heading with the Basanku. So, as I said, of the 70 tests that were run with the blood smears, about 78 of them tested positive for malaria. The rapid test is about 55% of them that tested positive for malaria. It turns out to be almost the same similar. It is really the reflection of the weakness of the health system in the DRC. I think one of the reasons why the lack of laboratory testing capacity on common diseases still constitute a major challenge. The reason why we reported last time that one of the legacies of Mpox in countries like DRC, Central African Republic, Burundi, Uganda is also to ensure that we do help them scale up laboratory testing capacity for these common diseases that can then allow them to make the diagnosis on time and also initiate the treatment to be able to reduce the case fatality as it is observed. And then on the timeline for testing, I think what we discussed with the National Minister of Health is that there will be a team that will be deployed from Kinshasa that will be deployed to also support the provincial team to improve the quality of the investigation. I think that is going on. The team will be going there next week. And we hope that in the next 2 weeks maximum, we should get the report of the investigation on one side, but also the confirmed report of the laboratory to ascertain exactly the disease that is striking, if it is once again malaria. That is known to be endemic in most of those areas, but then in certain season can then pick up to create this kind of outbreak that is being observed. Now, on the clade 1A, the ApoBec 3 mutation that we are talking about, it is often observed in clade 1B, and that's even what explains the high transmissibility of clade 1B. Now, our concern is that because 1A has got higher case fatality rate than 1B, if then 1A becomes also highly transmissible like 1B, the risk is that we'll see the case fatality of 1A increase. I think that is the main concern that we have at Africa CDC and also the IMS in general with WHO, is that really mutations like this just come again, to compromise all the effort that are in place and move toward high case fatality and higher morbidity than we have seen with the current 1A. Now, on Paul's question about the main focus of phase 2 following the recommendation to extend the status of emergency on Mpox as public health emergency of international security and international concern and continental security. What we have defined, what we have called the intensification phase, to give ourselves really to get the outbreak under control over the next 3 months, so that the last 3 months of this second plan should be the early recovery, while we'll be putting a greater emphasis on the resilience and also the legacy. That's why we like the last 3 months to focus on strengthening the system, especially in areas that contribute to epidemic or pandemic preparedness, or detection and response. But primarily, what we have identified is to improve surveillance. Surveillance is key, as we have reported that we have in some countries up to 80% of all the cases that are being reported by health facilities. What does that mean? It means that we are dealing with passive surveillance instead of active surveillance. What we are introducing during this phase is community-based surveillance through community health workers. I think there will be more than 2,500 community health workers that will be deployed, that will be conducting active case search around confirmed cases. They'll be also responsible for the listing of contact and also the monitoring of those contacts for 21 days, because we really want to make sure that all the cases, more and more, we get the cases, the new cases coming out of the contact list, which is in a way reassuring that the cases are now coming out of the chain of transmission that we do control. I think that's one priority. And on surveillance also, it is the digitalization of surveillance with different tablets that are being distributed to ensure that we also get the result on time. If you've seen, for example, we just reported the DRC there, that drop of about 800 cases from the previous week. It's not that there have been a drop in the number of cases, it is delays in reporting. I think that's the reason why we are also moving into the digitalization of primary healthcare facilities, but also of community health workers that will be working on surveillance to ensure that the data is complete, it is of quality, but also it is transmitted on time. The second major area, it is on laboratory capacity testing, that we are also working to ensure that it is true that in most in countries we've seen, even what we are hearing now about the freeze on US funding, the way it is affecting the sample transportation. I think this is because they don't have testing capacity on site. They have to transport samples very long distance, sometimes even more than 1,000 kilometers, not just to run. But you can imagine the turnaround time. I think we're asking one of the countries, they told us that they did an assessment. The turnaround time result for those remote areas gets up to 90 days. Now, if it's 90 days, that means everyone that had to be exposed is already exposed. Now, at that time, the only thing you have to do is just to provide case management. There's no more prevention, really, that will not add much value because it has come just too late. That's the reason why the decentralization of laboratory is one of the priorities in this second phase, to ensure that within 24 hours, the alerts are investigated, but as soon as they are confirmed, then the samples are collected within 24 hours and the results are available within 48 hours. That will really collapse the time that the communities are being exposed to the virus. And I think the third thing that is also extremely important that I mentioned is the introduction of community health workers. As you know, that community health workers have played a very important role in programs like the promotion of key family practices, the management of diarrhea, pneumonia, and malaria. But now more and more they are playing a much bigger role, in health security, especially in emergency preparedness and response. It is also one element that we like in the context of the 2 million community health worker initiative of the African Union, also to ensure that all these countries do have strong community health worker programs that also include a strong element of emergency preparedness and response. I think those are some of the main focus areas as we move forward. We plan really to implement them in a way that we can leave them as a legacy, as well. And then finally, the last one is vaccination. You remember that we have received more vaccine. I say 1.4 million allocated, 750,000 that have already been shipped, but just 200,000 that have been used, administered. That is one of the areas that we are also intensifying to make sure that we can really scale up vaccination to be able to protect the population and also contribute to controlling this outbreak in the months that are ahead of us. Yeah, I think then you had another question, Paul, on the pause on US funding. Yeah, we reported last time that there's an assessment that Africa CDC is undertaking, both the impact on Africa CDC itself, but also on the member state, and on the member state, including in specific support to the Mpox response. That exercise is still ongoing. It is not yet completed. I think as soon as it is completed, I think we'll have the opportunity to share the outcome with you. Thank you very much, Director.
Thank you very much. Let's move on to the next question. Makochi from BBC, you have the floor.
Okay, hi, Doctor. Thank you for the answers. Just wanted to know, the new Clade 1A in the DRC, do we have any idea if this has been also observed in any other country, let's say neighboring countries or, other countries outside the continent? Thank you.
Thank you. Let's take the next one. Carmen from Politico, you have the floor.
Thank you so much, Margaret. Dr. Ngashi, you've probably seen news that yesterday the U.S. State Department canceled about 90% of the grants and contracts that the U.S. Agency for International Development was running. We're hearing that obviously this affects a lot of programs, many of them on the African continent. Have you started hearing from across the continent about the potential impact of this? So this is not frozen anymore, it's terminated. Yeah, can you speak to any of that at all?
Thank you. Dr. Ngashi, over to you.
Yes, thank you very much. Yeah, I think on Makochi's question about the new strain is not yet observed in any other country. I think DRC is the very first country that we have observed that. But what happens is that every time that you see something that is been detected in one place, then we have to ensure that the sequencing that is also happening in other Central African countries where we have seen Clade 1A, like Central African Republic, or in Congo Brazzaville, I think in those countries will very much encourage also the sequencing that to be following now to also look into the ApoB3 in particular. I think that's something that we are going to follow. But for now, no other country has reported that. Now, on the USAID question, very important. I think we really expect that African countries will be affected seriously. We are talking about over 6 billion. I think that was coming to Africa, and USAID is one of the main contributor to the 6 billion that was coming. We've already started seeing, I think, some of the effect. It is true, as I say, that the assessment that we are conducting now will give us more information. But already, even in Mpox, in Uganda, and in DRC, I think both countries have reported that the decline in the testing coverage for Mpox is linked to USAID that was supporting the sample transportation. Now with the pause or the cancellation of this funding, I think all that has collapsed. I think that's the reason why we have confirmed that we have already started seeing, I think, the effect of that. But the most important is that we have also initiated some of the strategies. For example, you heard about the meeting we convened at the African Union with President Kagame as the champion for health financing in Africa, to start now digging into the domestic financing. So how do we also increase domestic financing as one of the ways that we can fill the gap? In addition to that, you have heard already in previous press conferences that we've gone ahead with the African Epidemic Fund, and that we are thinking around innovative financing mechanism that can allow us also beyond domestic resources to raise some of the funding on the African continent, as well bringing alternative financing options that can help somehow reduce, if not fill the gap completely, but reduce the gap that will be created by the US cancellation. Thank you very much, Larry. Over to you.
get the next question. Esther Nakazi from Uganda, you have the floor.
Thank you, Margaret, and thank you, Dr. Ngashi. My question is about vaccines for Mpox to Uganda. You rightly have observed that cases are going up, but we are not getting any more vaccines here, and in other African countries, I guess you're not supplying more. So what is happening? And secondly, we do have home-based care that has been recommended by the government. And I wonder, is there a definition, a standard way of providing home-based care that you can tell me about or recommend, or that is recommended by Africa CDC? And lastly, the place where the new disease is manifested in DRC, does it have the same setting similar to Mpox where it was manifested back then? Are there any similarities or it's completely different? I just want you to paint a picture of what it looks like. Thank you very much.
Thank you. Let's take the one more before Dr. Ngashi comes in. Priyanka from Chemical and Engineering News, you have the floor.
Thank you, Margaret. Dr. Ngashi, it's great to hear that there's talk about decentralization of laboratories. I'm just curious to know to what extent, on the ground, will there be decentralization? And is there a goal for X number of laboratories to be erected, depending on, what kind of funding is available? Thank you.
Over to you, Dr. Ngashi.
Okay, thank you very much. Okay, Esther, on your question regarding vaccines to Uganda, I think the initial allocation of vaccine to Uganda was 10,000 doses that were given to Uganda. And then because of the increasing number of cases in Uganda, there was a second allocation of 100,000 doses. Now, we were ready to, everything has already been done. I think all the documentation, the acceptance has been received from government. All the documentation have also been received. I think the only thing that was left is that Uganda had requested for us to give those vaccines in batches of 25,000. I think that was a challenge because some of the partners were also putting pressure that if we go slowly like that, some of the vaccines will fall below 6 months of shelf life. I think, and finally, we took a little bit of time to discuss with the Minister of Health, and that has been now recently, we received now a letter from the ministry confirming that they are ready to receive the 100,000, and in the next 1 week or two, I think Uganda should be able to receive the 100,000 doses. You see, it's a tenfold increase from the initial allocation, just also taking into consideration the turn that the outbreak has taken in the country. On home-based care, I think this is the reality. I think based on the increasing number of cases now overwhelming the capacity, of the treatment centers, I think the government has made that decision just to ensure that less severe cases can be taken care of at home. Now, in the package of home-based care, you have the care of the skin lesions, I think it is the clinical care. You have the psychosocial support that will be provided by community health workers, I think that will be visiting. And you also have the support with infection prevention and control. I think that will give you some of the PPEs to those that will be taking care of the sick, and all that is part of the package. And Africa CDC is very much supporting the government. I think there are guidelines that were already developed with WHO, on home-based care of Mpox cases. I think those are the guidelines that all the countries that are doing it, are following. Is that the support to ensure that there are community health workers that are supporting the homes, that you have all the supplies to take care of the wounds, and you have the infection prevention and control supplies. I think all that is included in the package that is going to be provided. Now, the disease X that we are to the febrile illness that is happening now is in a different place. It is in the Equatorial region, which is the northwest. Yet Panzi was the southwest. I think there are 2 different provinces where this has happened. Now, on Priyanka's question about the goal, yes, I think that's first of all, in terms of what approach or what strategy have we opted for the decentralization, is to have the Gen expert machines in the district, at the district level. In DRC, they are called health zones, but in Uganda, they are called district. And then at the regional level, we have the qPCR. And then at national level, we keep the capacity for genomic sequencing. That is the strategy. And now, just to estimate that, for example, in the DRC, we have the initial support was to establish 56 Gen expert machines in the 56 hotspot health zones, equivalent to districts in other countries. That was the first. And then the second was to also support 7 qPCR machines in the 7 provinces that represented those 56 health zones. And all that came to a budget of about 6 million. And most of these machines are in the process of being delivered. I think the 7 qPCR machines are already in the country, being distributed, and even the capacity strengthening for the Gen expert machine, is ongoing. It's a similar exercise that we are doing, in all these countries, in Uganda and Burundi, in particular, because they are really the most affected countries. Thank you very much. Over to you, Director.
Thank you, Dr. Ngashi. And with that, we have come to the end of the weekly briefing this week. I will hand it over back to Dr. Ngashi for his closing remarks. Over to you, Dr. Ngashi.
Thank you very much. Let me first start just by thanking all of you for being with us during the first 6 months of this Mpox response. We have to say that it is the first time that we have done it this way, and we are happy that we did it this way to also establish a mechanism that allows us to feed back to you, to make sure that we are accountable to you, to give you feedback on the progress that we are making on the ground. But we are also sharing the challenges that we are facing, and use you also as our ambassadors, as we work together to ensure that there's great momentum really in the international community to support the Mpox response in Africa. We have completed the first phase. Many positive achievements, as I mentioned. Out of the 22 countries that have been affected, we have 9 that are already, 8 that are already in control phase. We have 14 that are still active, but 8 of those 14 are already in the declining phase, which is also good. Then we have 6 countries that are really on the upward trend, but of those 6, only 2, that's Uganda and DRC, that where you have the highest numbers. The others like South Africa, South Sudan, Sierra Leone, we are talking about sporadic cases, those few cases that we have all learned that we need to be as aggressive as possible when the cases are still few to prevent them from expanding further. Just to say that now we've gotten the extension from both Africa CDC and WHO, which is really good news. We are delighted, for one thing, is to see the harmony between these 2 organizations, and also the harmony between the 2 levels of our organization. We have a continental declaration, we have a global declaration. And then we review after 6 months, the continental say, where we stand, we need to extend. The global also relooks at the data again, and also come to the same conclusion. We are all proud, really, to see that kind of alignment, harmonization, and coherence when it comes to outbreak management in the continent. But we know that the second phase will be the most difficult one, because now there's no more time for complacency. We have to show results, and time is really running. We continue counting on all of you, and we'll keep you posted every week on how we are managing this second phase of the outbreak. With those few words, I would like once again to thank all of you again for your attention, for being with us today, and we look forward to seeing you again next week at the same day, at the same time. Thank you.